Peripheral arterial disease, AD, also known as peripheral occlusive arterial disease, is a condition characterized by the narrowing or blockage of arteries, primarily in the lower extremities, due to atherosclerosis. The investigations and management of PAD are critical for improving patient outcomes and preventing complications such as ischemia and limb loss. 1. Clinical evaluation. History and symptoms. Intermittent claudication, cramping or pain in the legs during exercise that is relieved by rest. Rest pain, pain in the lower limbs at rest, especially at night. Non-healing ulcers or gangrene. Risk factors: smoking, diabetes, hypertension, hyperlipidemia, and family history of cardiovascular disease. Physical examination: palpation of pulses e dorsalis pedis, posterior tibial, popliteal, femoral. Auscultation for bruits over arteries. Inspection for trophic changes, e.g. hair loss, shiny skin, ulcers, gangrene. Capillary refill time and temperature changes in the affected limb. 2. Non-invasive diagnostic tests, ankle brachial index, ABI, a simple non-invasive test comparing blood pressure in the ankle and arm, normal ABI 1.0 to 1.4, PED ABI 0.9, ABI 0.4. Treadmill exercise testing, used to assess functional limitation and unmask PAD in borderline ABI results. Segmental limb pressure measurement, measures pressures at multiple levels of the limb to localize the site of obstruction. Pulse volume recording, PVR, assesses arterial waveforms and blood flow volume in the limbs. Doppler ultrasound, identifies the location and severity of stenosis or occlusion, provides information on flow velocity and turbulence. HAIR-3 imaging studies, duplex ultrasonography, combines traditional ultrasound with Doppler imaging to visualize arterial structures and assess flow dynamics. Computed tomography angiography, CTA, provides detailed images of blood vessels using contrast material, useful for planning revascularization procedures. Magnetic resonance angiography MRA, non-invasive imaging technique that provides high-resolution images of blood vessels. Digital subtraction angiography, DSA, gold standard for diagnosing PAD. Invasive and involves catheter placement and contrast injection, allows for simultaneous diagnostic evaluation and therapeutic intervention. Laboratory investigations, lipid profile to assess dyslipidemia, blood glucose and HbA1c to evaluate for diabetes mellitus, complete blood count CBC to rule out anemia or infection. Inflammatory markers, high sensitivity CRP, HSCRP, may indicate systemic inflammation. Renal function tests, important for assessing risk related to contrast-based imaging. Management. Management of PAD involves lifestyle modification, medical therapy, and, in severe cases, surgical or endovascular intervention. 1. Lifestyle modifications. Smoking cessation, most critical step to halt disease progression. Exercise therapy, supervised exercise programs, e.g., walking on a treadmill, to improve functional capacity and claudication distance. Recommended at least 30 to 45 minutes 3 times per week for 12 weeks. Dietary changes, low-fat, low-cholesterol diet to manage atherosclerosis. Encourage Mediterranean or DASH diet. Medical management, antiplatelet therapy, aspirin or clopidogrel to reduce the risk of cardiovascular events. Statins, high-intensity statins, e.g. atorvastatin, rosuvastatin, to lower LDL cholesterol and stabilize plaques. Antihypertensive therapy, ACE inhibitors or ARBs preferred to control blood pressure. Glycemic control, optimized management of diabetes with oral agents or insulin. Cilostazol, phosphodiesterase inhibitor to improve walking distance in patients with intermittent claudication. Contraindicated in patients with heart failure. 3. Revascularization procedures indicated for patients with severe symptoms, critical limb ischemia, or non-healing ulcers. Endovascular techniques, balloon angioplasty, stent placement, atherectomy, plaque removal. Surgical options, bypass surgery, creation of a graft to bypass the occluded artery, endarterectomy, removal of plaque from the affected artery. 4. Management of complications, critical limb ischemia, CLI, urgent revascularization, pain management and wound care, amputation as a last resort for irreversible gangrene. Infection management, aggressive antibiotic therapy for infected ulcers or gangrene. 5. Long-term follow-up, regular monitoring of symptoms and ABI. encouragement of adherence to lifestyle changes and medical therapy, periodic reassessment of cardiovascular risk factors. Conclusion: the management of PAD requires a multidisciplinary approach involving primary care physicians, vascular surgeons, and interventional radiologists. Early diagnosis and aggressive treatment of risk factors can prevent disease progression and improve quality of life.